Pleasure today to host this very, very important topic on infectious disease forum in immunocompromised, because this continues to plague us and continues to have morbidity and mortality. To understand these diseases for decades, we have been utilizing the antibiotics and the antiviral things empirically. But today, as the diagnostics stewardship has kicked in and the diagnostics have become more rapid in nature, today we can utilize those rapid diagnostics to actually identify our problem in India. Till now, we have been reading everything from the Western world. Now with Dr. Neha around, we have been able to discover a lot of viruses which are prevalent into various seasonal variations which are there in Indian context. So it gives me an immense pleasure to allow Dr. Neha to start this webinar, where she has done a wonderful job in the setting of bone marrow transplant, kidney transplants, and renal transplants in Fortis Group, and has been able to reverse the MDR rates for the first time in a decade-long fight against antimicrobial resistance. So over to Dr. Neha. Wish you all the best, and it will be a great subject and a great learning across the India, because I'm sure that 300 to 350 plus people across Middle East, across from CIS and across India will be joining in today. Over to Dr. Neha.
Thank you so much, sir. Thank you, everyone. And welcome all to the second session on the forum of Infectious Disease Forum in Immunocompromised. So in the continuation of those diseases, and especially, whenever we say the double trouble, the infection itself, and then second, the host factor population, which is quite immunocompromised, it is very important to diagnose right in time and with the right modalities, and also sometimes how to interpret those reports, especially the topic which is of today, is both way very important, that A, how to pick it up in time, and B, what to be done when you know that this particular virus is there. And as Rahul sir has really laid the context, that this time of the year is very, very important, and especially in the terms of the respiratory viral infections, because common cold, as the name suggests, it's so common that every Tom and Dick and Harry, every other person will be landing up with the upper respiratory tract infections. So in that perspective, respiratory viral infections, especially in the immunocompromised category, which right from the beginning includes all the oncology people, hematology patients, transplant patients, both the hematopoietic as well as solid organ, it's very really important to understand them in the time and treat if needed. We have with us today the great speaker, Dr. Michael Isson. Sir, actually in the ID world, he needs no introduction because he is the editor-in-chief of one of the dream journals, which is Transplant Infectious Disease Journal. Sir is a recipient of prestigious Robert Rubin Transplant Infectious Diseases Community of Practice Award from the great American Society of Transplantation. I mean, I can go on in Sir's thing. He is a chief in the respiratory diseases branch at the NIH. He is the director of Northwestern University Clinical and Translational Science Institute at Chicago. More than 200 plus publications in the field of respiratory viral infections, especially in the HSCT and SOT, and 350 plus talks and presentation as the esteemed speaker, and I've been one of his patient listeners for a while in the many national and international conferences. So without wasting a further ado, over to you, Isson sir, for your presentation, and really looking forward to learn from you. So
wonderful. Thank you. If you take the slides down, I'll share mine.
Sure, sir. Just one sec.
You'll need to stop sharing.
Right.
Perfect. Well, I want to thank Neha for reaching out to me to give this talk. I think it highlights the real wonder, despite some of the changes recently, of Twitter or X. It's I think allowed people to connect with others and be recognized globally for their contributions. So today I'll be talking about respiratory infections in the immunocompromised. I had a number of potential conflicts of interest, all of which ended in December 2022 when I joined NIH. I do continue to get royalty payments from UpToDate, and I'm the paid editor-in-chief for the Transplant Infectious Disease Journal, as Neha pointed out. So the outline of my talk today will be talking a little bit about the epidemiology of respiratory virus infections, and then I'm going to focus on 4 viruses that have the best data for prevention and treatment. So I'm going to start by talking a little bit about the epidemiology. And what I will say is that for a variety of reasons, these infections tend to impact 2 immunocompromised populations the most: lung transplant recipients and stem cell transplant recipients. They clearly can affect others, but the greatest impact and the greatest research are performed in these 2 populations. It doesn't mean that the others don't get these infections, but as I'm going to try to highlight, predominantly with solid organ transplant data, really the investigation and impact is greatest in these 2 populations. So I'm going to start with this study from the Swiss transplant cohort study, and they looked at the cumulative incidence of respiratory viral infections in lung transplant patients in red and all other non-lung transplant, solid organ transplant patients in blue. And again, I think this really highlights that there's a significant difference in the relative incidence of disease over time, such that as you get further out from transplant, nearly all lung transplant recipients have a respiratory virus infection, whereas less than about 10% at 7 years of other solid organ patients have a diagnosed respiratory virus infection. As we all know, they all have infections, but they usually aren't severe enough to warrant seeking clinical care and therefore go undiagnosed. And then if you look at the relative epidemiology of these viruses, again, I think that this highlights what the patient is presenting with and how much testing is being done in these populations. On the left-hand side, you can see the lung transplant population, and you see a spread of respiratory viruses that are in an order that I would expect for overall seasonality of viruses, with rhinoviruses being clearly the most commonly identified pathogen, followed by RSV, coronavirus, and then influenza among lung transplant patients. And as we'll see in a minute, this also mirrors what we see in this stem cell transplant population. For non-lung transplant patients, you see the opposite. So influenza is the most commonly diagnosed pathogen, followed by a much lower rate of rhinovirus, which again just highlights these patients just aren't coming in for care and not being tested for these viruses. In terms of seasonality, this is the US seasonality. This will be different in India, where the seasons may be different, and the epidemiology of some of these viruses may be different because there may be either 2 seasons or continuous circulation of the virus. But in the US, there's really, and this is Switzerland, I should say, which is very similar to the United States, in that you see in the winter months things like flu, RSV, and human metapneumovirus being the predominant viruses. In the summers, we see the other viruses, with the fall and spring really predominating with cold viruses, rhino and coronaviruses. This is, of course, before COVID-19, and we're again seeing kind of, at least in the US and Europe, 2 predominant waves of COVID-19 in the winter and in the summer months. I think it's important to recognize that there are differences in symptomatology across the different viruses, but this is where a study that was done in the stem cell transplant population, I think, graphically more clearly shows this. So this is a study from the University of Washington where they looked at the predominant symptoms of various respiratory viruses. And you can see things such as fever, which should be a predominant symptom for influenza, for example, is only present at clinical presentation in about 1/3 of patients. And things like stuffy nose, sinus congestion, cough, or runny nose are common for all of the viruses. And so this really highlights the fact that there are cardinal symptoms that may not be diagnostic and so are important to recognize because they may be a trigger for testing. And that classic symptoms like sore throat and fever, which are usually a paramount symptom for influenza, may be absent in the majority of the immunocompromised patient population. I think the other thing that's important to recognize is that unlike most healthy patients, that if they get a acute respiratory infection, they tend to recover. Maybe we'll get a bacterial superinfection, but in transplant patients, both stem cell and solid organ, here's solid organ lung transplant populations, you see a number of different acute complications in addition to the virus itself. You see an increase in the risk of invasive fungal infections, particularly when there's lower tract involvement. This is more common with PIV and RSV, but can be seen with influenza. Increased risk of bacterial infections, and then a risk in lung transplant patients of increased graft failure and chronic lung allograft dysfunction or chronic rejection in these patients. This has been clearly shown in the lung transplant population, but on the right-hand side are data that, again, comes from the University of Washington, which really shows that this kind of chronic airflow disease is a complication in the stem cell transplant population as well, particularly in those patients that have lower tract involvement, particularly with parainfluenza virus. And so if you have lower tract paraflu, RSV, you can not infrequently develop late onset airflow obstruction where there's progressive loss in PFTs, which is associated with reduced survival and adverse outcomes. So let's shift our focus to some of the kind of key viruses that we're going to focus on today. We'll start with influenza. The mainstay of prevention is vaccination. Historically, there were concerns because early studies showed poor efficacy, and there were some early case reports of rejection associated with vaccination among solid organ transplant patients, and poor responses, particularly early post-transplant in the stem cell transplant population. What has come out of decades of research with influenza is that, in fact, the efficacy isn't as bad as initially thought. Probably somewhere around 70 to 80% of the protective efficacy of healthy individuals. But that there are some important things, and I'm going to highlight this plot down in the lower left-hand side, where you can see a dashed line in the control patients, normal, healthy, immunocompetent patients, and the solid lines, which are the immunocompromised solid organ transplant recipients. And what you can see is that they generally have an increase in antibody titer, but to a much lower degree than you would see in a healthy individual. And this is important because if you don't push the titers up high enough, you may not get protection, and you definitely will have decay sooner, so that even if you have protection early after vaccination, that protection may wane before the end of the influenza season. And so a number of different strategies, including 2 standard dose influenza vaccines, use of adjuvanted vaccines, intradermal vaccines, or high-dose vaccines have been studied in the stem cell and solid organ transplant population to really improve the vaccine responses. And so how do they do? I'm going to focus on this study here, which was a recent study that I think was probably the best done because it compared 2 potential interventions: high-dose vaccine or MF59 adjuvanted influenza vaccine compared to standard dose vaccine among solid organ transplant recipients. And what you can see is that you increase the antibody response without adding a lot of reactogenicity. But despite that, you really aren't seeing a significant drop in the rate of influenza, maybe a little lower in the MF59. It wasn't statistically significant. And so really, I think that what this highlights is that these do generate higher antibody responses. Whether or not they impact a lower rate of influenza, again, probably needs bigger studies than these with just about 200 patients in each arm. One potential option for our patients, either when vaccine isn't available or where we suspect that the vaccine is not going to be efficacious, such as early after stem cell transplantation, is the use of seasonal antiviral prophylaxis. This was a study that we did a little over a decade ago, in which we randomized stem cell and kidney and liver transplant recipients to either receive seasonal influenza, 12 weeks of oseltamivir 75 milligrams once a day during the day when they're most likely to have exposures, versus placebo for 12 weeks. And what we were able to demonstrate is a significant 75 to 88% reduction in the proportion of PCR or culture-confirmed influenza. It also highlights one of the real challenges with doing the studies in the immunocompromised patients. For this to become an indication for the vaccines, it would have to reduce clinically symptomatic and laboratory confirmed influenza. And only about 10% of the patients had clinical symptomatology. And so while statistically significant in preventing infection, those with symptoms were too low of a number to really show statistical significance. And so it's in the package insert in the United States and Europe, but not a specific indication. That said, very well tolerated. We did not have a high rate of intolerance. And of those patients that had breakthrough infection in the prophylaxis arm, none had documentation of resistance. So again, I think in the really highest risk population, this is one potential intervention. For example, if there's a big outbreak of influenza or a pandemic of influenza, and your patients, for example, are early after stem cell transplantation, this may be an intervention to help give them better protection than the vaccine would provide them themselves. And again, it's important to note that about 85% of patients in this study were vaccinated. So this is in addition to vaccination. Available agents, we have a number of agents that are available. The M2 ion channel inhibitors, amantadine and rimantadine, are not currently recommended because all circulating seasonal strains are resistant to this class of drugs. Neuraminidase inhibitors, oseltamivir and zanamivir, as well as peramivir, are available in the United States. Lananamivir is available in some countries in Asia. Lananamivir is a long-acting inhaled medication, whereas the others require 1 to 5 days worth of treatment. There are a number of polymerase inhibitors. Baloxavir and favipiravir are the ones that are most widely available that may be associated with reduced frequency of infection. There are a number of studies that have looked at the early treatment in transplant patients. Most have not been prospectively collected. They, though, have consistently shown reduced mortality, reduced shedding, and reduced progression to pneumonia. There are some studies, as I'll show in a second, that also seem to show a reduction in the incidence of bronchiolitis obliterans syndrome, but their use may be associated with resistance, as we'll talk about here in a second. I think it is important to recognize, and the graph on the right-hand side is from a study from Basel, in which they looked at serial patients. Almost all were receiving antiviral therapy while PCR positive. And you can see every patient had persistent shedding despite antivirals for at least 7 days, suggesting that these patients probably benefit from a longer duration of therapy beyond the standard 5-day course. Probably the best study is this one that came from Dipali Kumar's group, where it was an observational study, so patients got treated per the providers. They, on average, got oseltamivir for 5 days, with about 80% of patients receiving therapy. This included stem cell and solid organ transplant patients. And a couple of themes came out. Again, a sizable proportion of patients, nearly 50%, were still shedding at day 5 of therapy. So again, needing a longer duration of therapy may be important. Those with lower tract disease really do have longer shedding. And again, I think one very useful finding of this study too is that if they were vaccinated in the current season and had breakthrough infection, they had a lower viral load and more rapid clearance. So again, a talking point when you talk to your patients about the value of vaccination in this population. Even if you have a breakthrough infection, you're more likely to have better outcomes in those patients. This is a study that we did when I was a fellow, where we looked at early treatment with oseltamivir in lung transplant patients. These look at the serial PFTs in the patient, and you can see at the time of diagnosis, almost all of the patients had a reduction in their pulmonary function testing, with most getting back to normal at about 3 months. 2 patients had progressive decline or chronic rejection. These patients had pre-existing CLAD prior to the diagnosis, and their decline in pulmonary function post-infection was at the same rate as seen prior to this. This is important because you would expect to see a third of these patients developing new CLAD after infection without treatment, again, suggesting this early treatment is associated with prevention of chronic rejection in these patients. Lastly, one question that comes up that we finally have some data on is whether or not to use high-dose oseltamivir in the immunocompromised population. This was a study that looked at a broad range of immunocompromised patients, including stem cell transplant, solid organ, and HIV patients, as well as hematologic malignancy patients, which accounted for the majority of patients. And what they found is by using a high dose of oseltamivir, 150 milligrams twice a day in patients with normal renal function, you had a significantly lower risk of detection of resistance at the end of therapy, 15% in standard dose versus 3% in the double dose. So again, my approach to using high dose is if it's a stem cell transplant or oncology patient currently undergoing chemotherapy, or a stem cell transplant recipient within the first 6 months after transplant, or lung transplant patients, I will use the higher doses of oseltamivir to prevent resistance. There was no difference in clinical outcomes in these patients, so it's not improving the acute outcome, just preventing resistance, for which we have very limited treatment options. We have a newer therapy, baloxavir. This has the advantage that it drops viral load very, very quickly compared to oseltamivir. We did a study in high-risk outpatients with oseltamivir compared to baloxavir, compared to placebo. And by chance, this was the first study that this happened. About half the patients had influenza A, H3N2, and half had influenza B. And this really allowed us to interrogate the differences of these two classes of drugs. Historically, influenza B, oseltamivir is less active against, and clinically, patients have more fever, more duration of symptoms, and longer shedding with influenza B than A when treated with oseltamivir. And we confirmed this in this study. So patients infected with influenza A, clinical resolution was about a day faster, as shown in the red and the blue, red being baloxavir, blue being oseltamivir, compared to the placebo green arm. And we saw virologic declines in both arms as well. For those patients infected with influenza B, there was no difference in clinical resolution or viral clearance between oseltamivir and placebo, suggesting that if you have a patient infected with influenza B, maybe baloxavir is the drug to reach for in your immunocompromised patient population. We also performed this study, the Flagstone study, in which patients were randomized to receive standard of care in general, oseltamivir, or baloxavir plus standard of care among hospitalized patients. We saw in the upper graph in pink a very rapid decline in viral load compared to standard of care alone, but that was not associated with improved clinical outcomes. And in fact, we looked at every possible outcome possible, and there was no clinical improvement. The one thing that we were able to see is reduced emergence of resistance. So in baloxavir patients infected with H3N2, you'd expect to see somewhere between 10 and 30% of patients having detectable resistance at the end of therapy. In the combination therapy arm, we did not see any emergence of resistance. And in fact, those patients that developed resistance had dual resistance to both oseltamivir and baloxavir, and both were immunocompromised. So again, still a risk, but that is a reduced risk from what we would expect to see with monotherapy. So again, perhaps in those most immunocompromised patients, there's a role for combination therapy, recognizing in this study the combination was not just a single dose of baloxavir, but baloxavir given every 3 days with oseltamivir for 10 days. Switching direction to RSV, there's been a lot of focus on antivirals, particularly ribavirin, and I'll really try to talk with you about how I think it really provides no significant benefit. We had a sea change in the field with the approval of RSV vaccines. There are 2 vaccines, one from GSK called, at least in the US, Arexvy. It's an influenza A, an RSV A only. It is studied as a single dose versus annual dose, and it's an adjuvanted vaccine. And then a bivalent A and B unadjuvanted vaccine from Pfizer. It was only studied as a single dose and without adjuvant. Recently, Moderna has also had their mRNA vaccine approved. This again is an mRNA unadjuvanted vaccine. These really did show similar outcomes, showed that up till now there isn't been a need to give booster doses. There's very limited data in the immunocompromised patient population. Pfizer publicly disclosed that their immunocompromised study is completed. Unfortunately, we don't have a lot of data, and from what little is out there, I think that it's not going to help us too much for the patients that we care for, because it seems that most of the patients enrolled were patients with rheumatologic conditions, which have a very different vaccine response. Again, there's been a lot of enthusiasm, particularly in lung and stem cell transplant recipients for the use of ribavirin. This was fueled a couple of years ago by this meta-analysis of treatment strategies, which suggested that ribavirin for RSV may reduce the risk of chronic rejection. But again, oftentimes these were coming from non-randomized study. At least in the United States, due to the high expense of inhaled ribavirin, most have abandoned the use of inhaled ribavirin and switched to oral ribavirin. The challenge is you don't get probably adequate therapy to treat the virus. We have really only this study that basically had two different patients, one that started with aerosolized ribavirin and then switched to oral ribavirin, and another that had oral ribavirin switched to inhaled ribavirin. And what you can see with the oral ribavirin, you really get very low levels of the concentration of the active metabolite, probably at or below what is therapeutic, whereas with inhaled therapy, you get 100-fold higher rates of levels, again, suggesting that maybe we're not doing anything other than treating ourselves with oral ribavirin. Switching briefly to COVID-19 treatment guidelines, really, at least in the United States, approach to immunocompromised patients is very similar to otherwise healthy patients. I think one of the things that has been recognized is that certain patients, those that are lymphodepleted, those that have received rituximab or similar B-cell active therapies, do have prolonged shedding and do have emergence of resistance. And in those patients, use of dual therapy is probably needed for a longer duration of time. When we had monoclonals, oftentimes it was a monoclonal plus an antiviral. More and more, there's been efforts to try to look at antiviral combinations. Oftentimes, in patients that progress that are hospitalized, we will still use immune modulators. Emerging data is starting to show that this probably is associated with an increased risk of infectious complications in these patients compared to non-immunocompromised patients. And the clinical benefit may be slightly reduced in these patients. So again, I think we need more data, particularly in this patient population for chronic shudders and those that progress despite therapy. Lastly, I thought I'd spend a few minutes talking about parainfluenza virus, another challenging virus that we really don't have good therapies. This is one where the data is quite clear that ribavirin plus or minus immune globulin really does nothing to improve outcomes, and in fact, mortality may be no different in those patients treated versus untreated. And so really no role for IVIG or ribavirin for parainfluenza virus. We do have a drug, DAS-181, which is now in phase 3 testing after some early preliminary data and compassionate use studies showed benefit. We'll have to wait and see what the final study shows to see if this is an alternative. In the phase 2 study, really only benefit was seen in a very small subset of patients, early post-transplant with upper tract disease. Those already presenting with lower tract disease did not appear to have significant improved outcomes, and those that had progressive that were further out from transplant also did not seem to have a lot of benefit. And this is where I think some of the scores, either the Basel score or the MD Anderson infection score, immunosuppression scores are really helpful if they have a relatively high state of immunosuppression. I think this is where I do favor the use of therapies, whereas if they have a lower score, I think that that's a little bit less. So with that, I'm going to wrap up and finish with the take-home points. Epidemiology is greatest for lung and stem cell transplant patients. Rhinovirus, which in general I think, except in the most immunosuppressed patient, really is not an actionable virus. We have no therapies. IVIG definitely does not benefit those patients. Infection is more likely to progress if early post-transplant. There's an increased risk of chronic lung rejection and chronic airflow obstruction in these patients, as well as a higher rate of invasive fungal infections and bacterial infections. Atypical infections are more common, and so really you need to have a low threshold. If they have fever or any respiratory symptom, really think about treating those patients, and then the earlier you intervene on those patients, probably the better. For influenza, neuraminidase inhibitors in the most immunocompromised, we may need higher doses for longer periods of time. Baloxavir, I generally wouldn't use monotherapy, with perhaps the exception of influenza B, where I would favor its use over oseltamivir. RSV, we need better therapies, but so far those that have been studied have generally failed. Standard of care is ribavirin, but I actually think it doesn't work orally, and you really need nebulization, which is prohibitively expensive. For SARS-CoV-2, probably our most immunocompromised patients, particularly those with B-cell defects, need combination therapies, ideally with monoclonals if they're available. And then if you're going to use the oral therapies, recognizing that there's oftentimes significant drug-drug interactions that need to be addressed. So with that, I know Neha let me know that there's a lot of questions. So I'm going to stop screen sharing and be happy to answer questions that people have.
Well, thank you so much, sir. That was really, really very much enlightening. You know, the cascade of all the viruses, all the RVIs you have explained in such a comprehensive way. And definitely all these viruses do bug us. So yes, we have a lot of questions. And like I said, that this is the time of the year where we are almost flooded with both the question and the viruses together at the same time. So I may ask there are a few questions which a lot of our other colleagues have also piled up. So first, very important question. So like you just said that, you know, the viral infections are not only the risk in per se, the primary presentation, but also the secondary sequelae in the form of the invasive fungal infections, superadded staphylococcal infections, and streptococcal. So how is the surveillance strategy when we know that there is a particular seasonality in majority of the viruses, and especially in the lung transplant and HSCT, if I target, what is your routine surveillance strategy, or is there any recommendations on that?
Yeah, so I think in general, as we were talking a little bit before the session got started, I do think that there has to be a comprehensive surveillance strategy for the hospital. This also needs to be shared with the community as well, because if you collect the data and don't share it in a useful way with the providers, it's hard for them to act upon. Oftentimes, this is driven by clinical presentation. And so, with that, I think you just need to have a low threshold. Again, as I kind of highlighted at the end, our approach really is to demonstrate that a patient has either fever or any respiratory symptom, and that's a trigger for doing testing. I think understanding what the dominant virus is, I think, can really be helpful in understanding, do I need to be worried about these patients or not? If you're seeing mostly rhinovirus and seasonal coronaviruses circulating, I think if patients are presenting with those symptoms, I would still test them, but it makes you need to start thinking about other interventions for these patients.
Understood. So, yeah, right, sir. Very rightly said. And in fact, extrapolating to that exactly the point, another question which even me and there is another person in the chat box wants to ask, because we usually adopt those multiplex PCR techniques as an upper respiratory panel or something like a nasal swab or a oropharyngeal swab panel. So many a times, because the immunocompromised patients have very subtle symptoms to begin with and a low-grade fever with a lot of other background things going on. So how you take that approach that you have an rhinovirus being picked up or a PCR detected, or for that matter, any enterovirus being detected. So are they the colonizers? Are they the true pathogens? One, of course, you mentioned about the clinical correlation, but is there any cutoff, or how do we approach these cases?
Yeah. So I think rhinovirus is a bit of a challenge. So what we know is that patients that are infected shed for an incredibly long period of time, can be 6 months. And the other thing is we don't really have good therapies for this. IVIG is treating the doctor. It's actually not doing anything to shorten the duration of symptomatology. There have been some studies that do show that, again, mostly in the most immunocompromised patients, there is a risk of progression to pneumonia. But again, that's less than 1%, even of those highly immunocompromised patients with rhinovirus. And so in general, it's something that if the patient is symptomatic and nothing else is identified, if they're waiting for a stem cell transplant, I may wait until they stop having ongoing symptoms. If they're asymptomatic and it's just picked up, again, I tend to ignore rhinoviruses and seasonal coronaviruses. I don't give them IVIG. I don't do much of anything. You'll have to follow your local infection prevention protocols. Oftentimes, they will trigger isolation for respiratory pathogens if it's present. But again, I think that it's not something for rhinovirus in particular that I take too seriously in the majority of patients.
Right, so and in the same context, I would ask that the COVID other strains. So because many a times the PCR picks up that NL63 or OC43 strains. So what about that? I mean, in the same context, if I may ask.
So for seasonal coronaviruses, I think it's effectively something I 100% ignore. Again, I think if they're coming in for their stem cell transplant and they're symptomatic, I think that is something that I would hold until they stop being symptomatic. But seasonal coronaviruses, for the most part, incredibly rare to cause severe lower tract disease. Does it happen? Yes. It's incredibly rare. But again, I think outside of that setting, again, we don't have good therapies. We may start looking at some of the available therapies, but again, since their clinical impact, they don't even seem to be associated with development of late onset airflow obstruction in these patients. So again, I just don't really pay much heed to the seasonal coronaviruses.
Understood, sir. One very particular question, because this is one of the two patients which we have just seen in last week. Both of them are stem cell transplant patients, and they had a GVHD ongoing, so they were on immunosuppression, sir. And then they developed some kind of respiratory illness, shortness of breath. We underwent a radiological imaging, and there were the mixed picture kind of a thing, which is common a scenario that you are not able to delineate that which kind of pathogen is that. So we went ahead and we did the bronchoscopy. And apart from the galactomannan being positive, which was quite a strong positive, we also underwent the viral screening and we found out the CMV in the bronchoalveolar lavage being detected. So the question for you is that mere presence of CMV in the person, and the one of the patient was mechanically ventilated, because there has been a lot of data which says that it can be a bystander reactivation, both in immunocompetent and immunocompromised in a ventilated patient. So a presence of CMV in the bowel, of course, we need to dig it further by biopsy, but in the cases where biopsy is not feasible, how to take that forward? Is there any cutoff or viral load for that, and how to go about it?
Yeah, so I wouldn't proceed to biopsy just by the presence of a detected CMV in the BAL, whether it's by culture or by PCR. Really, I think no one should be doing qualitative PCR on the BAL. What we do know is even among healthy immunocompetent patients, a sizable percentage of patients that are stressed in the ICU will have detectable virus in the lungs. There have been studies that have shown that a threshold of about 10,000 copies in the BAL is the point, if it's above that, where you do have to start being worried that the patient truly does have CMV pneumonitis. I would also check a blood CMV viral load, because while you can get CMV pneumonitis without a positive sample in the blood, detection in the blood, it's very unusual. So I think if you had just a positive in the BAL and negative in the blood, I would probably just monitor the patients. But again, qualitative tests probably have no role for BAL. It's quantitative PCR is the only testing that we should do. And until I had the quantitative PCR, I wouldn't even pursue biopsy, because it's a very morbid condition and probably more times than not, it's not going to be helpful for you.
Just for our audiences, sir, can you repeat the cutoff for the viral load in the bowel fluid?
Yep, 10,000 copies per ml. And again, you have to keep in mind that different assays have different thresholds, but that's sort of what's been established across multiple platforms. So around that range.
Understood. Before I take up the further, there is one very important audience question that the vaccination strategy, is there any difference between the lung transplant versus the other transplant? And if yes, how is it, sir?
Yep. So the way that I would think about it is I would think about three groups: lung transplant, non-lung transplant, solid organ, and then the stem cell transplant population. So first and foremost, on all patient populations, particularly, I would say more important on the stem cell, or sorry, on the solid organ side, is to really make sure that the patient is up to date for vaccine prior to transplant. Studies for flu and COVID-19 have clearly shown those patients that are up to date on vaccine pre-transplant not only are better protected post-transplant, but when they get booster doses post-transplant, they have a better response than patients that aren't up to date coming into the transplant. In terms of stem cell transplant patients, I think you have to contextualize with what's going on. If the patient's actively getting chemotherapy, they're not probably going to respond very well to vaccines. And so oftentimes what we'll do is use some other intervention to prevent the infection until post-transplant. Post-transplant for all patients, again, we follow the whatever the national guidance is. And so there, for stem cell transplantation in the United States and Europe, there's a guidance about revaccinating for respiratory viruses and non-respiratory viruses post-transplant. That usually starts for non-live vaccines, 6 months post-transplant. Although with some of the data that's come out, both for flu and for SARS-CoV-2, perhaps moving even closer into 3 months post-transplant, you would get adequate response. I think one thing that we probably don't pay as much attention to is the issue of vaccinating close contacts and people in the hospital. Oftentimes these patients are taking measures to protect themselves, but particularly if there's kids in the household where that risk is incredibly high, making sure that everyone, including the children in the household, are fully vaccinated for all of the pathogens can really be life-saving for our immunocompromised patient population. Likewise, reminding these immunocompromised patients that masks do work. And so when there's high prevalence of disease, if there's others in the household that have respiratory illnesses, keeping distant and wearing masks when around those risk settings can be helpful in preventing transmission.
I truly agree, and I just echo your fact because nowadays, for past 1 year, sir, in all our allo HSCT, because they need a little time post-transplant to get vaccinated, we are also following that ring vaccination strategy for them to vaccinate all the household contacts about specifically from the respiratory viral infections. In the same context of vaccines, sir, 2 more questions coming up. That one is about the adjuvant, the augmented dose versus the standard dose of influenza vaccine, number one. And second, which you have already mentioned in one of the slides, and also about is there any change in the frequency? The biannually versus the annually, because of the lot of heterogeneity in the different population and because of the seasonal influence. Is it okay to have it once before the peak of the season, or it's always important to have twice in a year schedule for especially lung transplant and bone marrow transplant?
So the approach that we use, and again, I will say I am not familiar with a lot of data in countries that maybe have bimodal flu peaks. I think what's been clearly shown is that 2 doses of vaccines, whether it's standard dose or high dose vaccines, improves outcomes in antibody levels in flu infection, and then booster vaccines at least once every 6 months for COVID-19 seem to benefit the immunocompromised patient population. I'll start with COVID-19. I think my approach, that what I tell people is just every 6 months, just plan to get a booster. It's and schedule your the booster at a time that sort of is in that interval. And ideally, again, now we're starting to get a sense of when the peaks are going to happen. So make sure that boost is coming, 4 to 6 weeks before you would expect that peak to occur. For flu, our approach is where we have one flu season is to give 2 doses of vaccine. I want the first dose before the flu season really starts, but if you physically can't get them, the second dose, really a month is really the interval that you need to keep the vaccines apart. For best response, and maybe longer is also better. It's perfectly fine to give the second dose in the middle of the flu season, because at that point they've already generated a response. You're trying to push that antibody response further. I think if you had a biphasic flu season, it may make sense to kind of do a dose before each peak, and that may be beneficial. But again, I haven't seen data to specifically look at that. I think it's an important question that needs to be investigated.
Understood. So that means that augmented dose once before the season, or a standard dose, as you mentioned, one after the another month. One versus the other, sir, which one? If I have to choose just once before the season.
I think the data suggests that adjuvanted or high dose vaccine is probably the better approach, but there's not good data to compare one to the other. The Swiss data really, I think, was the only one that did that and didn't show a significant difference between the two.
Right, sir. Okay, so the two very important questions coming up, because we have been a lot of times talking about that apart from few specific antiviral, one common strategy for almost all the viral infection is IVIG. So how actually beneficial it is. It is just the kind of a thing that, okay, if we are giving IVIG, we are sort of sorted. B, if yes, sir, what should be the dose and the frequency?
Yeah. So, there's not great data to support the use of IVIG for any indication. And again, I think you have to think about, what are you trying to do with the IVIG? The IVIG, in theory, increases antibody levels against pathogens that you want to prevent. I think the challenge with IVIG is that oftentimes you're using IVIG that represents old exposures. So for COVID-19, while there are data that show that in immunocompromised patients that the use of IVIG in the course of treatment may be of benefit, the real challenge is, as we've seen, there's oftentimes antigenic drift. And so the antibodies that are present in IVIG typically reflect what was circulating in humans 6 months or longer ago. And so you probably don't have the kind of same levels of antibodies in those patients. That's particularly true with flu, where out of season, again, the majority of what's in IVIG is from the prior year. And if there's been antigenic drift, it may not be providing a lot of benefit. The one virus where there is some evidence to suggest that there's benefit comes for RSV, where the use of inhaled ribavirin plus IVIG in non-comparative studies does seem to be associated with the lowest mortality and progression to lower tract disease. So that would be one where there may be a benefit. If you look at a lot of the other viruses, so for example, PIV, the amount of PIV antibody in IVIG pretty low, and I think we now have strong data to show it doesn't do anything for PIV. For rhinovirus, likewise, there's hundreds of different types of rhinovirus and seasonal coronaviruses, and again, relatively low levels. Adenovirus, likewise, total waste of resources to give IVIG. There's almost 100 subtypes. And many of the subtypes that our immunocompromised patients get are not the common ones in otherwise healthy patients. So the circulating antibody level for those are incredibly low. There have been studies that have shown that it may be associated, IVIG may be associated with reduced risk of bacterial infections. Again, the data is a little bit softer. So again, I think it's not unreasonable to try it if that's the goal. I also think not going too crazy with kilograms and kilograms of IVIG. I just don't think it's really doing that much other than, again, treating us.
Or a single dose, sir, in case if we are using, or alternative dose or something? Because many papers of the RSV sometimes suggest that there is an off-label usage of data of the alternate 0.5 gram per kg for the 3 doses or 5 doses. So what dose?
Yeah, if you were to use it, I just use a single dose. I've never given multiple doses. Again, if you're going to bump the antibodies, it's not as though the infection is going to sop up all of those antibodies. So again, I don't see much of a benefit. And then again, going back to the other question about CMV pneumonitis, again, I think this is very controversial. I think most people will still give IVIG or CMVIG. Again, the more contemporary data suggests that may not be super useful or essential in our patient population.
Right, sir. And the same from the RSV perspective, the presence of RSV in the nasal swab or a OP swab versus the presence of RSV in the swab plus the HRCT findings, the cutoff of usage of both the ribavirin and IVIG.
Yeah. So this is where, and I realized I didn't include the slide for that, but there's two scoring systems, one developed by the MD Anderson group. Roy Chimale is the senior author on that, and another from the Basel group. Hans Hirsch is the lead author. I did have a reference for the Eisen-Hirsch review paper in Clinical Microbiology Review, where we have a nice table that shows both of these scores. I think this is where it's helpful among stem cell and oncology patients to really calculate that score. If they're low risk, their risk of progressing to lower tract disease is relatively low, and so I tend not to do anything. In those patients with high risk, those are the patients that I'll still kind of, even though I don't believe the data, maybe consider ribavirin and IVIG. For patients that don't have lower tract disease, the data is pretty clear. Once they have lower tract disease, all these therapies are just moving ships on the Titanic. There's a very high rate of mortality, particularly the higher the risk. It's almost 90% mortality if you have lower tract disease. So I think it's also helpful for discussions with the family that to be realistic that this is associated with very poor outcomes, and we just need to keep our minds on that outcome.
Understood. So that's a very important learning for us as well, because many a times we do see that, okay, we have a lower respiratory infections, and the inhaled ribavirin is a little difficult for the procurement, especially in our setting. So we still have only access to the oral ribavirin, sir. So I know the data are quite dismal, but then if I have to compare the two formulations of ribavirin, how come is a very good, what is the efficacy rate from the oral ribavirin?
So there's not been prospective randomized trials for oral. It's generally like people said, oh, outcomes are similar. I think I point to the fact that the data is very soft. And then with oral ribavirin, you're not getting drug in the lung that's of concentration to affect the virus. And that's basic pharmacology. Like if you don't give enough drug, you're not going to do anything to the pathogen. And so again, I think we need prospective studies. There also have been 2 studies looking at newer therapies for the treatment of RSV. They didn't randomize ribavirin, but in the lung transplant population, only about 70% of patients got treated. In the stem cell transplant population, it was about 60%. And there was no difference in viral decay between those patients that received ribavirin and those that didn't. So again, my read, oral ribavirin is not doing anything other than treating us.
Right, absolutely. Understood, sir. 2, 3 more questions, sir, since the time is running short, but we have a lot of questions, so I'm just selecting out. The another thing is that with the new advent of new BiTE antibody therapies, new bispecific models, and the CAR-T, so is there any difference in the paradigm and spectrum of the respiratory viral infection, especially the post-CAR-T therapies, because that is a recent buzz amongst the transplanters?
Yeah. So there's an effort that I'm participating in being led by the ID Society of America that's trying to look at this, and we just presented our review of the literature. It's for most of the interventions, it's the way the data has been collected, to be quite honest, it's hard to really make a comment. There does seem to be a higher rate of respiratory infections, but that oftentimes is including bacterial, fungal, and viral infections. It, to really tweeze down particularly pathogen-specific findings, that's been hard for us. So we're going to not have a firm conclusion on that. Again, I think oftentimes there's conditioning that goes with some of these. So again, I think probably paying more attention to what's going on with the lymphocytes. Do you have sufficient number and functionality of the lymphocytes? If you do, your probably risk is closer to a healthy patient. If they're low, then there's risk of progression.
Right. Understood. One very important question, sir, that steroids. Of course, we will always avoid the steroids at the first initial viremic phase. But apart from the clinical progression to the severe form of ARDS, any other indication, especially in the RVIs, where we place steroids?
Yeah. So I do think we should be avoiding steroids as much as possible in these patients. Steroids result in an increase in viral replication. What has been shown in, for example, stem cell transplant patients is if they're on kind of low dose, 5-10 milligrams, continuing that probably doesn't affect the outcomes, but giving them steroid therapy is associated with worse outcomes for flu for sure, and suggests that for RSV. So outside of stress dose steroids for sepsis, I don't think we should be using them in our patient population. That said, there are some ongoing studies looking at the use of steroids as standard of care for treatment of influenza. And I think if those show differences, we may have to readjust our way of thinking, but for the most part, I think I try to avoid steroids as much as possible. They definitely are associated with an increased risk of invasive fungal infections. And so again, there are downsides. And again, I think many times people view it as, oh, this is a safe thing to do. It's not in these patients.
I agree. So there's one question on the COVID, sir. So the take on Paxlovid, because of its many a times proposed drug interactions, because of the molecule per se with the other concomitant drugs being used, how to place Paxlovid in the recent times in the immunocompromised population?
Yeah, I think it depends a little bit on the patients. There are some patients that are not receiving therapies that are essential for their ongoing care that can be held for a short period of time. If that's the case, I think Paxlovid is an option. I think if Paxlovid has significant drug interactions for things that can't be stopped, like immunosuppressive medications, some centers may have the capacity. It requires a lot of close monitoring of patients and a careful plan. That said, still many patients end up with high levels of immunosuppression, which again may be associated with toxicity. So in general, we would favor the use of non-ritonavir containing agents for the treatment of our most immunocompromised patients. We don't have tons of options, at least here in the United States, so it's usually molnupiravir. But again, that would be kind of the approach that we would take for most of these patients.
And the same is applicable to the recent strains which are circulating, because here we are using just the symptomatic approach, sir, supportive and symptomatic.
Yep. Yeah, there's really there's no difference in terms of susceptibility for the more recent strain with the small molecule oral agents. Monoclonals, that's a different story. I think at least in the United States, we have a monoclonal that had activity against this currently circulating strain. It may be losing some of that with some of the emerging strains. We'll just have to see how that plays out.
Right. So I think we are nearing towards the end of the talk. And I think one last question, if I have to ask you, is that the lung GVHDs, because a lot of patients from the HSCT group are being posing that lung GVH requiring a more of the chronic steroid or an inhaled steroids, I would say, and a FAM-based therapy protocols. how to have a prophylaxis-based approach in that set of patients.
Yeah, I think so. So in general, or in the setting of respiratory virus?
So in respiratory viruses specifically.
Yeah, again, I think if they're chronically on steroids, particularly inhaled steroids, I wouldn't stop them. Again, I think they can be safely continued. Steroid use, inhaled or systemic steroids, are associated with increased fungal infections. And so I think it probably would have to be contextualized with current rates in your hospital. There's been suggested incidence above 5 to 6%, that if your rates are higher than that, then you may want to consider a month or so of antifungal prophylaxis in those patients. Alternatively, just close observation and testing of those patients if new symptoms or radiologic findings emerge.
Understood. Well, I guess no more questions from our side. And if all okay by your end, I would really like to at the onset to thank you so much, sir, for that wonderful webinar, followed by a whole lot of questions to answer. And we will be more and more enlightened today after listening to you. Thank you so much, sir, for being a part of it and giving us a great talk on that very, very important question and a topic in this specially part of season. I would now hand over to the Emcure team, who has been helping us for creating these kind of platforms with so much of stalwarts in the field to come and deliver a lecture on this important topic. Thank you, sir, again for accepting our invite and be a part of it. And over to the Emcure team.
Thank you very much, Dr. Neha. I heartily thank Dr. Michael Eisen for taking out time, and the whole Fortis team, starting from Dr. Rahul, Dr. Nikhil, and Dr. Neha. I'm very glad that we are able to be your partner in such educational series. So thank you very much. We hope we get to see more of all of you. Thank you.
Thank you, sir. Thank you, everyone.
Thank you.
Bye-bye.